Hello everyone, I'm Bryan from Singapore, and I would first like to congratulate the All India Ophthalmological Society for putting together this educational module entitled Step by Step MIGS. And I would like to thank Professor Namrata Sharma and Professor Tanuj Dada for inviting me to be part of this. My talk will focus on an exciting and still developing area, the use of intraoperative optical coherence tomography in MIGS. These are my financial disclosures, some of which are relevant to this talk. I will first give an overview of the intraoperative optical coherence tomography, or the iOCT. I will then discuss some of its potential applications in MIGS, in both trabecular bypass MIGS, as well as in MIBS, or minimally invasive bleb surgery. The OCT as a non-contact imaging tool was first developed 30 years ago. And it was around the year 2007 that the OCT was first introduced into the OR. The surgical microscope only allowed surgeons an on-fast perspective in surgery, and it was hoped that the iOCT would provide better visualization of tissues and better appreciation of depth. The earliest iOCTs were portable, handheld devices that were initially used in pediatric patients or patients unable to sit upright at an OCT machine. When they were used in the OR, they were connected to a mobile OCT scanning station, which were operated by an assistant in the OR itself. However, they could also be mounted onto surgical microscopes using a custom arm attachment, which allowed the surgeon to continue to operate with both hands. The iOCT would then be connected by a fiber optic cable to the scanning and display station. Over the last decade, however, the iOCTs began to be incorporated into the surgical microscopes themselves. The three integrated iOCT platforms which have been FDA approved are the Opmi Lumera with the iOCT from Carl Zeiss, the iOCT from Hug Stride, and the Enfocus Intrasurgical OCT from Leica Microsystems. These integrated iOCTs brought with them several advantages over the portable iOCTs. These included less delay during surgery, more real-time imaging and less time lag, and as mentioned, they were now fully integrated into operating microscopes, creating much more stable combined platforms. The use of the iOCT is perhaps most well known in retina and cornea surgery, but in recent years, the use of the iOCT has also picked up in glaucoma surgery. These are two systematic reviews that we have published summarizing the applications of anterior segment imaging and more specifically the intraoperative OCT in both traditional glaucoma surgery as well as in MIGS. In more traditional glaucoma surgery, literature has reported the use of the iOCT in trabeculectomy surgeries, in bleb needling procedures, transconjunctival bleb suturing, goniosynechiolysis, as well as in glaucoma drainage device implantation. But how about in MIGS or minimally invasive glaucoma surgery? Does the iOCT have any potential role to play in this spectrum of new and emerging surgeries? Well, in terms of trabecular bypass MIGS devices, there are two that have been approved by the US FDA. And these are firstly the iStent series and secondly the Hydrus Microstent. These trabecular bypass devices are a subset of angle-based MIGS. They are performed under intraoperative gonioscopic guidance, with stents implanted into the angle, bypassing the trabecular meshwork resistance, and directly assessing the Schlemm's canal, hence enhancing physiological aqueous outflow and reducing the intraocular pressure of the eye. Now, these devices are designed to be placed precisely and accurately in the angle. For the iStent devices, the head of the stent should rest in the Schlemm's canal, as seen here. For the Hydrus Microstent, almost the entire length of the stent should be placed in the Schlemm's canal where it serves as a scaffold, with the inlet remaining in the anterior chamber. Clinically, this is what should be seen at the end of surgery. For the iStent device, the flange of the stent should be seen right at the posterior pigmented trabecular meshwork, with the thorax or body embedded in the TM itself, and the head of the stent resting in the Schlemm's canal. For the Hydrus Microstent, The 3 windows should be seen blood-filled and visible in the Schlemm's canal just behind the trabecular meshwork. The inlet should be exposed up to half the transition zone. However, malpositioning can and does occur. With the iStent devices, the stents may be too low or too high above the posterior pigmented trabecular meshwork, or under or over implanted. The stents would have to be repositioned to ensure good outcomes, and these are some ways in which we can manage these scenarios intraoperatively. For the Hydrus Microstent, similarly, the stent may dive or dip below the Schlemm's canal, or the tip of its distal window may extrude out, or the entire stent may not even be placed in the angle at the initial implantation attempt. Malpositioning of MIGS is important to avoid because there is growing evidence that malpositioned MIGS devices do not achieve optimal IOP lowering efficacy. This study showed that iStent inject devices that were not placed optimally in the angle, as determined by post-operative OCT scans, resulted in suboptimal post-operative IOPs and less dilatation of the Schlemm's canal. But unfortunately, malpositioning occurs more than we think. Studies using clinical gonioscopy, the ASOCT, or the gonioscope have revealed that a greater percentage of iStent devices may be malpositioned than previously thought. This is where the iOCT may play an important role in MIGS. In my clinical practice, I use the Opmi Lumera with the iOCT from Carl Zeiss. I've published on how one may use the iOCT intrabecular bypass MIGS. Here, I've implanted the iStent Inject W, and I'm using the iOCT to image the stents. I'm imaging the stents under intraoperative gonioscopy guidance, and here are the horizontal and vertical cuts. While the deeper head and thorax are not visible due to signal loss, you can appreciate the excellent resolution of the iOCT in imaging both the flange and even the 80-micron lumen of the stent device, which should lie just above the trabecular meshwork. You can imagine how the iOCT would then be able to help us reduce the risk of under- and over-implantation of the iStent. Under-implantation, in particular, may be missed with the wider flange of the iStent Inject W, particularly on just the on-fast view of the surgical microscope. This is one such example. Here, I'm implanting an iStent Inject W device. On the on-fast view, it looks implanted in an appropriate location, does not look over or under-implanted clinically, and I'm even giving it a gentle nudge to ensure it is well embedded in the angle. I implant the second device uneventfully, but you can see that as I move my iStent delivery device across my first stent, it gets dislodged more easily than I would expect, indicating it may have been under-implanted in the first place. You can imagine how using the iOCT would have quickly and easily revealed this under-implantation. Under-implantation, of course, is not without sequelae. This was a patient referred to me with a dislodged iStent Inject for management. Over the course of follow-up, the iStent device was noticed to have dislodged completely and was now resting in the inferior angle of the eye. It was likely to have been under-implanted in the first place, and this again could have been avoided with the use of the iOCT. The iOCT can also be useful during implantation of the Hydrus Microstent. Here, as I'm centering the iOCT on the window segment of the Hydrus, on the horizontal cut, the Hydrus appears as a hyperreflective line just lying beneath the surface of the TM. And on the vertical cut, I see what I call the tram track sign, 2 short curved lines lying just at the angle. Upon centering the iOCT on the spine segment, on the horizontal cut, I see again the hyperreflective line, and on the vertical cut, this time I see what I call the knuckle sign, a curved line pushing upwards at the angle. The iOCT may be particularly useful for Hydrus implantation in eyes with very heavily pigmented trabecular meshworks or with dense iris processes. In these eyes, visualization of all 3 windows of the Hydrus in the Schlemm's is difficult, and thus the iOCT would be helpful in confirming the placement of the stent. This was one such case of mine. This angle, as you can see, is open but densely pigmented. And while the Hydrus grows in very smoothly, I suspect that the Hydrus may be diving below the Schlemm's canal. But I'm unable to visualize the stent behind the very pigmented TM. I then use the iOCT, which confirms good placement of the stent, but only up to the second window. You see the metallic sheen of the stent just behind the trabecular meshwork in both axes. However, distal to that, I cannot see the stent even with the iOCT. It is likely that the hydrus begins to dive right at this point, just beyond the second window of the stent. I decided then to remove the hydrus, and in observing the orientation of the stent while removing it, I see that the hydrus was indeed not placed correctly in the first place. I proceeded with phacoemulsification first, before implanting my hydrus in the inferior angle, which as you can see was successful, with the visualization of all three windows of the stent in the schlems. And this was confirmed, of course, again with the iOCT. The iOCT may also be useful in the ab-externo implantation of stents in minimally invasive bleb surgery for both the XEN45 Gel Stent and the Preserflo Microshunt. In Preserflo Microshunt implantation, the iOCT can be used to visualize the entry of the guide needle, ensuring its safe and accurate entry through the angle itself, that it does not enter too posteriorly toward the ciliary body, but instead anterior to the iris and also not too close to the cornea itself. It can also be used to visualize the lumen of the stent in situ to ensure no obvious blockage or occlusion with blood or debris. You can appreciate here the high resolution of the iOCT in imaging the clear lumen of the stent in this case. After the Preserflo Microshunt has been implanted, you can see how the iOCT allows us to be confident about the placement of the stent lying just anterior to the iris and well away from the cornea. This may lower any risk of endothelial cell loss, which may occur with too anterior an entry of the stent in the angle or too close the location of the stent to the endothelium. These are post-operative OCT scans of the Preserflo, and we can appreciate the good correlation between both intra- and post-operative OCT scans of the stent itself. In summary, there has been increasing application of the iOCT in ophthalmic surgery and in glaucoma surgery. I hope that I have further demonstrated the significant potential for greater use of the iOCT in MIGS, both to enhance intraoperative visualization as well as to improve the precision of device implantation. We look forward now to studies which can elucidate the impact of the iOCT on the surgical outcomes of these surgeries. I hope this has been helpful to you, and thank you for your kind attention.